Hello, welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to Occupational Therapy Conversations. In this episode, I'd like us to have a discussion about this process called screening. It's something that we are using all the time. It's something that people hear all the time. And I feel there is a need for us to understand it a little bit more. What do we mean when we're doing a screening? A screening basically is a process that happens before a thorough assessment or a thorough involvement of occupational therapy or before an occupational therapist gets involved. It's a screen. And what a screen does basically is it filters out situations, scenarios, and that's what it does really. So when you're doing screening, you're basically filtering out whether a person needs more in-depth occupational therapy input or not. And screening can be done by an occupational therapist. Yes, you filter things out. Or it can be done by other professionals on behalf of occupational therapists. Sometimes the referrers would conduct their own screening as well, and then they will make that decision if they will make a referral to an occupational therapist. Screening and active screening is a part of the things that we do. There are people that looks at things in a more thorough situation, just like triaging. Okay? So if you're there in the ward and you're doing a walkabout and you look at a patient and that the person is elderly and frail, and you start asking the question, how are you feeling? Do you live alone? And they say, yes, I live alone. And who's going to do the shopping for you? I don't know. Okay, that's just it. That's the screening. An occupational therapist then can start to ask questions more in details, but now you have come beyond the threshold of screening already. Now you are obtaining more information. You are going to problem identification. So you're now doing a thorough assessment this time around. That is a screening, and it's just a very single point, and it's a very short point. But what it does is it triggers whether the person would need more occupational therapy or not. Say you are working in a big ward or in a critical care facility where you are the only occupational therapist. What you're doing is you are possibly looking at the notes and to see whether this person needs occupational therapy or not. And how do you do that? You look at the notes and you identify medical cases, medical scenarios that can have functional implications for the patient. And when you see that there is a good chance that the person would have some functional impairment or some have performance component issues like cognition or delirium, this will be a problem. Then you've already used up that screening card and you are now triggered by the event and by the situation. And the next thing that follows afterwards is monitoring as to when you could come in, but you've already done the screening. It's just a one-off event that happened. Yeah. Say you've done that and you don't know, you've done the screening and you don't know what the outcome yet, whether this person would need, whether the person would need you or not. So you've done the screening, but you're still there. You're still monitoring, isn't it? You're now actively monitoring the case. You've already screened it. It just meant that you are worried. You don't know what's happening. You've done the screening and you have made that decision to actively monitor the case, whether you would be getting involved or not. Then that now becomes a different aspect of it. And now that one becomes a monitoring. When you do a thorough investigation and you start asking the patient, you are no longer screening. You're already identifying problems. And as an occupational therapist, it's very automatic for us to, after identifying the problems, to analyze and make solutions already. And when that thing happens, you're already thinking about the solutions. You're already planning. You're already doing something. And you're already planning your treatment and intervention, whether it's a direct face-to-face intervention that you're planning to do, or you are going to be doing an education. Okay. So that is screening, guys. And sometimes people just do away with this screening and they do not put a lot of importance to it, saying that it takes a lot of time for them. And it does take a lot of time. And what does that mean? If it's taking up your time, it meant that whoever is paying you, your pay is actually allocated to those times that you are spending on that. So if you are working 7.5 hours a day, and a good proportion of that is done on screening, is from 8 o'clock. Say you start at 8 and you finish at 4. You go into a board round meeting or whiteboard meeting. And after that whiteboard meeting for 15 minutes, you come down to the office, say at 7:30. And then you start looking at the notes, planning all over again, looking at the scenario again, looking at the notes in details. Okay. So this is either, if it was the first time, then you're just screening. But if you knew of the case and then you're reviewing it on a daily basis, then it is now monitoring. And when you are monitoring and you're spending time on that, it deserves to be logged as a valid activity, because what will be the outcome of that? The outcome would be an instigation for a more thorough assessment, an instigation for intervention and treatment. And when you are monitoring, say the person is not well and is in bed, wow, that will trigger some other occupational therapy programs. Like, for example, it will trigger a recovery monitoring and facilitation program, for example. What happens if you are in the ward, for example? Say you're in the ward, you're looking after a ward, and the ones that are doing the screening are the nurses. And if they find that there is a problem with the patient or the potential situation, potential problem, then they will then contact occupational therapy and will refer the case over to occupational therapy. So the ward is actually doing the screening. The nurses are doing the screening. A lot of the times, the screening that are done by the nurses, a lot of the times they're reliable, but equally, a lot of the times they're not overly reliable as well. But already, when they have the gut feeling and they ask, something is probably not right, and maybe this person is best be seen by an occupational therapist, and that is already a screening that they have done. And this problem triggered them to refer the case over to you. They're now asking for help. Can you please have a look? Okay. Really, it's always a hit and miss. Unless it's people's job to make that referral and it's to do their screening, When it comes to occupational therapy and the need for occupational therapy, the screening is a hit and miss depending on the experience of the screener or depending on whoever is doing that. They have to have a very good grasp of what occupational therapy does and what we can do for our patients. And when that is the case, then it is our duty then to start educating people so that what we get, the quality of screening that they get in the future would be much better as well. Okay. What else? The other downside, if you rely on the nurses and you depend on the nurses, sometimes we become an afterthought only. We are an afterthought when it comes to the ward. It's not the full priority of the nurses. Usually it's the medics, lots of things that they needed to do. And then they realize that occupational therapists can probably help, particularly on the discharge planning. And we then become an afterthought. Okay? So the solution really is, if and when you have time, do the screening yourselves. Make it easy for everybody else. Make it easy for you. If you have time, then you can do the screening. Just imagine this. Let's have an exercise. Imagine if you paid for every case that was referred over to you. Okay. Would you not be active in screening the case then? You would, wouldn't you? So our activity then changes based on the knowledge of what we are going to be getting, our productivity, our efficiency, and our value. Our value will be reflected and our activity will be reflected on our activity. Am I saying that right? There you go, guys. What are the actionable takeaway from this? I think the actionable takeaway is, do not underestimate the phase, the screening phase, because that triggers whether a person will need more occupational therapy. And you need to be proactive in one, educating the staff about what we do so you don't have issues about the quality of referrals that we get. And another thing is you need to be proactive in screening the patients if you have time to do that as well. If you are an established profession, then you don't have to worry about screening because referrals will just freely come. In the same way as there are demands for surgeons, there's demand for cardiologists, for physicians, and for GP. They do not need to have a referral. People just automatically screen themselves and they automatically self-refer themselves. Okay, here you go. I hope you learned a little something from this wonderful and very short conversation. If you enjoyed it or if you learned a little something, talk to your friends about it. Not about just the podcast where we're in, but have a discussion about that topic, the screening, while you're having tea. Talk to your friends about it. Better yet, subscribe, share, click on notification, things that you normally do, just to appease the algorithm out there. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.